In my discussions on establishing a truly preventive system of healthcare in the United States, I've frequently discussed what I call a parallel build-out. This refers to the challenge on the one hand of better managing the existing burden of chronic disease in mostly older Americans now, while simultaneously creating the necessary information, training, and financial infrastructure to support prevention-based or informed, incentivized, home-based, and multi-generational lifespan health planning on the other hand. There may, however, at least in part, be a way for these two worlds to intersect, and that would be to follow the lead and wise insights of this nation's palliative care movement. As populations age in the United States, chronic illnesses create an uncertain medical future. By 2030, a fifth of the U.S. population will be over 65, and many will face the challenges of managing one or more chronic diseases for a significant number of years, including physical and psychological distress, functional dependency and frailty, and the need for support. Traditional care systems are not particularly well equipped for this situation. For example, our medical system focuses almost exclusively on curing diseases and prolonging life, goals shaped by the hard-charging interventional past. But in the new order, these two worthwhile goals become hollow if they're not pursued simultaneously with goals of improving quality of life, relieving suffering, and providing physical and emotional comfort. The palliative care movement addresses this concern. Palliative care, which focuses on supporting the needs of the chronically ill as they approach the final phase of life, is as much a life philosophy and a value position as it is a caring revolution. Two leaders of the movement recently noted, quotes, "The aim of palliative care is to relieve suffering and improve the quality of life for patients with advanced illnesses and their families," close quotes. The process of getting there is as important as the goal itself. Palliative care calls for an extraordinarily inclusive team effort with a strong emphasis on planning. This philosophy of care begins with physicians eliciting the concerns of the patient and their loved ones. What is important in a patient's life? What more would he or she like to achieve? Is there something he or she fears worse than death? Concerns expressed during this conversation help define the patient's value system. Studies have found that patients almost always express the desire for more effective communication with their care team that is comforting and comfortable dealing with uncertainty and complexity. It's important for the care team to tailor care to the patient's individual needs. Palliative care is remarkably focused and pragmatic. If I place myself in an elder patient's shoes, multiple diseases, some compromise in capacity, but an uncertain prognosis, priorities become more obvious. What would I need? What would I ask of my caregivers? Well, first, relieve my suffering. Second, improve the quality of my life. Third, manage my pain and other symptoms effectively over the long span. Fourth, while you're caring for me physically, don't abandon me psychologically or spiritually. Help me grieve my losses. Fifth, be sure to coordinate this as a team effort, remembering that my family and I are part of the team as well. At the end of the day, the patient seeks enough comfort to contribute to loved ones' lives, enough resources to not be a burden to family and friends, and enough strength and capacity to control one's own life. Many people are dealing with these issues with their loved ones now, but it makes good sense to plan ahead for a time when this generation will have multiple medical conditions themselves, but will not yet be in the dying process. Where does hospice services fit in with palliative care? Well, hospice care has a remarkable track record in supportive, holistic, end-of-life care. In the United States, however, it's been primarily associated with terminal care of cancer patients. Insurance coverage for hospice services requires physician certification that a patient has only 6 months to live. Such certification in non-cancer chronic diseases has been difficult. But slowly, around the world, care systems are beginning to absorb the teachings of hospice in the form of chronic disease management, team coordination, and a holistic patient-centered care approach. When successful outcomes are well-defined, everyone benefits. How would a focus on palliative care benefit the build-out of a preventive, home-centered healthcare model? Well, a quick survey demonstrates compatible values and ideals. Patients should be able to voice their personal needs and define their long-term and short-term goals. Evaluation should be thorough on the front end and take into account what patients define as excellent outcomes. Team approaches should be utilized, and the home should serve as much as possible as the center of care. Care should be well planned based on these expectations, and discussions should be summarized in a formal planning directive, leaving little to chance. Trusted home health managers, both formal and informal, should be identified and integrated into the healthcare team. Were we to embrace such an approach, what would we find? Well, more joy and pleasure, less pain and worry, less hospitalization, fewer nursing home placements, greater patient and family satisfaction, greater caregiver health and well-being, and in the end, a greater likelihood of a life lived to its full human potential. For Health Commentary, I'm Mike McGee.